morning everyone. Happy to present today's seminar about ECG in congenital heart disease. When it comes to utilization of ECGs, we adult physicians or cardiologists use ECG to diagnose ILD and arrhythmias. But when it comes to valvular heart disease or congenital heart disease, we don't think much role of ECG and we do straight echo if we find any murmur or any suspending shunt in this patient. So ECG very underused in valvular heart disease or congenital heart disease. But what are uses of ECGs in congenital heart disease? I will be discussing this in today's seminar. ECG can be simple non-invasive tool to assist the diagnosis of congenital heart disease. It is a cost-effective tool to suspect and diagnose it. By hemodynamically significant structural heart disease may exist with insignificant ECG changes, but ECG can be useful as it reflects hemodynamics, reveal underlying pathology, and helps to cross-check with echo. So, ECG in congenital heart disease is used for various purposes like malposition, chamber enlargement, pericardial or myocardial disease, conduction abnormalities, arrhythmias. For arrhythmias, there is no other substitute than ECG. Electrolyte imbalance, and in congenital heart disease specifically assist in diagnosis, severity of condition, complication of associated conditions. So, why there is difference in pediatric ECG and adult ECG? We have to go back in physiology, that is what is physiology of fetal and neonatal circulation. To summarize this, in fetal inferior, the blood from umbilical vein reaches inferior vena cava. From that it reaches to right atrium, right ventricle. From right ventricle it goes in pulmonary trunk and whole lower body receives the blood from right ventricle. Plus some of the blood get crossed to LA through foramen ovale, and from that LV2 blood goes to upper body part, and at the level of after the left subclavian artery there is patent ductus arteriosus in fetal, and it shunt the blood from right ventricle to lower body. Here we can see that most of the blood in the body is getting pumped by right ventricle. So the fetal circulation or neonatal circulation is right dominant circulation. So what are physiological changes in circulation? At birth, pulmonary vascular resistance is far more greater than systemic vascular resistance. Pressure in both ventricles presumably equal at birth. With expansion of lungs at the ligation of cord, pulmonary vascular resistance falls rapidly and systemic vascular resistance rises, and right to left shunt across ductus ceases. RV thickness, structurally RV thickness remains higher than left initially, thus at birth tall RVs are recorded in right and especially mid precordial leads and deep especially left lateral leads. Changes in hemodynamics at birth are better reflected by T-wave variability than QRS compression. Means mostly the changes are in the form of T-wave. T-waves are positive on day 0 to day 5. It becomes negative by day 5 and remains throughout the infancy and early childhood. So contracting positive T-waves after 5 days of the birth are signifies some pathology in infant, like contracting adult ECGs. During first 72 hours, RV forces are more prominent than LV. The cardiac loop is usually clockwise by 6 to 2 months, and loop changes to counterclockwise. By 6 to 2 months, loop changes to counterclockwise loops. Loop is most anterior by 2 months of the age, and by 1 to 2 years it becomes more posterior. ECG from RV dominance to LV dominance lags behind the changes of ventricular weight ratio. Hence, although LV and RV weight equals by 1 month of age, and the ratio is 2.5 is to 3.1 by 3 to 6 months of age. Like at 6 months of age, the ratio is almost normal to adult, but ECG changes take around 1 to 3 years of age to normalize like RV dominance. So here is the slide about rotation. When there is clockwise rotation, there is equiphasic QRS complexes are shifted towards more at right side angles like V1, V2, and V2. When there is a counterclockwise rotation, the equiphasic QRS complexes will shift more towards left side angles like V5, V6. Here we can see that in clockwise rotation, the equiphasic QRS complex is V5, and in counterclockwise rotation, equiphasic QRS complex is V2. So What is the difference between pediatric and adult ECG? RV dominance is the rule till 3 years of age in pediatric ECG. The normal in pediatric ECG there is right axis deviation, tall R waves in V1 and AVR, T inversion in V1 to V3 that is juvenile T waves, upright T waves in V1 is abnormal after 3 days, which I have told already. There is short conduction intervals due to small heart, and there is high resting heart rate that in newborn is around 110 to 150. In 1 year is 100 to 135, that's 90 to 110. And we don't consider it as a pathological tachycardia in these conditions. So normal finding in children's heart rate more than 100, QRS axis more than 90 can be there. Right recorded D inversion, juvenile D inversions. Specifically, I want to tell about juvenile T wave inversions. Ideally this disappears by 3 to 5 years age, but in some individuals, like in females, they can persist up to young age also, around 20-25 years. We call it a juvenile persistent T wave inversions in right recorded V1 to V3, and this can be normal phenomenon. Dominant right recordal R waves can be there, short PR interval less than 120, QRS duration less than 80 milliseconds can be there. There can be slight peak T waves less than 3 mm, slightly prolonged QT, but less than 490 milliseconds in children. And respirophasic sinus are less common in children. So this is a normal pediatric ECG I am displaying here. Here we can see that T wave inversion in right recordal leads with prominent R wave in V1 to V3, and somewhat right axis deviation can be there. So coming to the case, I have been discussing here various 7 to 8 cases of different ECGs correlating pathological conditions in pediatric populations. Here 30 years old boy made with RTA, no significant past cardiac history, myalgia for injuries, called for abnormal ECGs. Here is the ECG. What abnormalities we can see here is, first when we look at ECG, we look at AVR. AVR is a positive. Second thing, we have to look at the recorded rates. There is a regression of the amplitude of QRS complexes as we go laterally, and there is also right axis deviation, and this is the ECG of sinus inversus dextrocardia in this condition without any pathological abnormality. So why it is sinus inversus? For sinus inversus, we have to see P wave direction. When there is a viscoarterial sinus solidus has upright P waves in lead 1 and AVL, and when there is sinus inversus, there is inverted P wave in lead 1 and AVL. Here we can see that lead 1 is inverted P wave, lead AVL there is inverted P wave. Although there is sinus dextrocardia, lead P waves can be positive, that can be altered by left atrial focus. In that condition, there can be dominant RT waves in V1, although patient has a dextrocardia. Regarding cardiac position, how we determine the cardiac position? Main is precordial R wave progression. Leocardia, in leocardia normal individuals, R wave progresses from V1 to V6 normally. In dextrocardia, there is regression of R waves, as we can see in this ECG, and mesocardia, mid precordial it shows tallest R waves. So, what are ECG features of dextrocardia? There is a right axis deviation. There is positive QRS complexes with upright T waves, lead AVR, and lead AVR and AVL are reverse. Lead 1 there is an opposite lead become inverted. So it is termed as technical dextrocardia due to the wrong lead placement, and it has to be ruled out with the pathological conditions. So coming to the next case of congenital heart disease. Here is the ECG, 3 years of boy with recurrent LR diabetes, systolic murmur at right upper tunnel border. In this ECG, we can see that there is a normal P axis behavior is positive with RSR strategy in V1, and there is a specific crotchety sign seen in inferior leads. Here we can see crotchety. So whenever the young patient with this type of ECG, we have to consider the positive secondary ASD. There is a specific crotchety sign in this patient. In inferior leads, there is a notch near apex of R waves, that is crotchety has been correlated with ASD. It is seen in 70% of the patient VSD, and it has a very high specificity, that is 92% of the patients have changes in all three lymph leads, and 86.1% of specificity if it appears in one lymph leads. This is a specific Congenital sign. Here it is more clear. At the peak of QRS complex, there is a notch with right bundle branch pattern. In young patient, we have to consider as post-stem primary VS, post-stem secondary VS. So, what is physiology behind these changes? RV volume overload, that is RV enlarges, so last to be polarized. Lengthening of right bundle branch block leads to incomplete right bundle branch block. Increased QRA duration in older age, clockwise electrical rotation, and lack of sinus arrhythmia in large ASD. First degree of heart block in post-stem secondary ASD, look for the limb abnormalities, that is familial ASD. Post-stem secondary ASD with cyanosis, think of PAPVC. So this is the second case. This 40 years of male with frequent LRDI, childhood, expressional palpitation and fatigue and weight. SpO2 96, that is acyanotic, and metasystolic murmur at the base of heart, and this is the ECG. What we can see in this ECG is left axis deviation with left anterior fascicular block. There is counterclockwise loop. Here we can see the prominent SQ in V6, that is counterclockwise loop, and there is also first degree of heart block. This is a typical ECG for post-stem primary ASD. Generally, ASD there is a right axis deviation, but when there is right bundle branch block pattern with LAFB with counterclockwise loop with clinical correlation suggestive of the disease, we have with first degree of heart block primarily.
PR interval કેટલો છે?
This is a 120 degrees.
લાગે છે ને એટલે
To borderline is borderline PR interval. Classical is first degree heart block. In post-stem primary we can classical first degree heart block due to the mild development of AV nodal fibers. Basically, so this is a classical post-stem primary ASD, but specific post-stem primary ASD I want to highlight is there is a RVBP pattern with left axis deviation, that is LAFB. This pattern can't be ignored in post-stem primary ASD. It can be associated with first degree heart blocks. So in third type of ASD, there is sinus venous ASD. There is a specific I want to mention is there in this type of ASD, the sinus node is pushed down, which is depolarized below upward, and there is inverted P waves in inferior leads. And there is a short PR interval due to sinus node come close to AV node. So specific findings of this sinus venous ASD is inverted P waves in inferior leads and short PR interval in this and RVB pattern. In this we have to think of sinus venous ASD. So considering the severity of shunts, when QP by QS ratio is more than 2, we can see there is more severe, and in this condition we can get severe right axis deviation, RE overload pattern, evidence of RSH or evidence of PAH can be there. Protruded sign can be there in severe shunt, and evidence of PAH, that is R wave in V1 is more than 7 mm. So second cyanotic congenital ventricular septal defect. It can present with normal ECG in small VSD, but with moderate to severe, there is a diastolic overload pattern in V5V6, that is tall R wave, QR pattern, prominent QS can be there in lateral leads, left axis deviation, broad and lost P waves. RV diastolic overload can be there in the form of RSR pattern in V1 and upright P waves in V1. RV systolic overload, that is tall R wave in V1. When the condition is progressive Gleason-Meyer syndrome, there can be PH and RV systolic overload with right axis deviation. The specific phenomenon I want to highlight in VSD is Katz's phenomenon. Here we can see this very large QRS complex in both right sided and left sided precordial leads. But there is equidiaphysial complexes in lead V2 and V4, that is R plus S more than 60. It signifies the biventricular hypertrophy and with large shunt and time to return. When this kind of ECG with mid precordial leads, that V2 to V4 have large complexes and equiphasic diphasic complexes, we have to consider this patient as a severe disease, and we can this is the time to intervene in this patient. This is a Katz's phenomenon, VSD type of violence. Other congenital diseases, obstructive disease, pulmonary stenosis, mild PS in the case of mild PS, its earliest sign is absent T wave inversion after 4 to 5 days of paralysis. If T wave are upright after 5 days, we have to consider some pathology in T waves. It can be associated with right axis deviation, right atrial enlargement, right ventricular hypertrophy, moderate PS. PR prolongation can be there in right axis deviation. In lead V1, RSR dash or QR pattern can be there. Right ventricular hypertrophy with strain in severe PS and neonate with critical PS. There can be signs of left ventricular hypertrophy due to hypoplastic right ventricles. This is the ECG of patient with severe PS. Here we can see that upright R waves in lead V1 with T wave inversion in lead V1. That is RV strain pattern can be observed here. Second obstructive disease congenital AS. In this condition, specific findings are like adults only, like LVH, LV state pattern. But in the infancy, LVH and LV state pattern are more significant because already there is a right ventricular state pattern can be there. So, with criteria for fulfilling the LVH and LV state pattern, that is all QRS complexes with downsloping ST depression in anterolateral leads, we have to see the severe AS and coagulate coagulation of fibers. In cyanotic congenital heart disease, there can be the two types of the increased pulmonary blood flow and decreased pulmonary blood flow. In which RV dominant disease includes transfusion of great arteries, single ventricle, DAT, and common artery. LV dominant disease includes tricuspid artery cell without PS and single ventricle, and biventricular dominance in truncus and single ventricles. With normal and decreased pulmonary blood flow, there is dominant LV circulation include tricuspid atresia, VSD, PS or pulmonary atresia with intact IVS, and dominant RV includes pulmonary hypertension. Present with Viswanath pulmonary hypertension absent in the cases like TOF, DO or VSD, PS or well. So coming to specifics, I will be discussing some specific diseases out of that, specific changes. In TGA, in the ECG we can get right axis deviation, RVH or biventricular hypertrophy or right atrial hypertrophy. Specific findings in TGA can be there is Q wave in lead AVR, right sided before leads and lead V1. Here we can see Q wave. Absent Q wave in lead V5 and V6. AV node is out of triangle of pop. It causes varying degree of heart block and abnormal septal activation can be there. CHP can be present with triggers. Specifically, I want to mention is absent Q waves in lateral leads. We have to think of TGA, we have to load. Here we can also see the mesocardia in lead V1 and absent Q wave in P6. Second, this is total anonymous pulmonary venous circulation, and this is present with the right axis deviation, right atrial enlargement, right ventricular hypertrophy. When it is a pre-tricuspid, it is a mild presentation unless obstructed. Posterior secondary ECG with cyanosis is the Q of TAP ECG, EST. And in truncus arteriosus, here we can see the picture. It is present with a simple biventricular strain, hypertrophy with strain pattern. Here is the another ECG. 30 years of old girls complaining of epilepsy, found to have some hole during heart during infancy, presented with cyanosis SpO2 80%, long systolic murmur at left tunnel border and pulmonary area. Here we can see the ECG. Here we can see this counterclockwise loop, that is prominent S wave in V6 and stereotypic typical peak body QRS complex. That is here we can see that only SSS wave is in V1 to V6. There is no R wave. There is a typical single pattern of the QRS in anterior list, termed as stereotypical QRS pattern. It can be observed in single ventricle. So this patient is a case of single ventricle. There is unusual ventricular hypertrophic pattern. Similar QRS complexes in recorded list that there is no IVS, and other abnormalities of Q wave is in right parasternal leads and no Q waves in here we can see the clockwise loop, sir, with RV dominance pattern. Typical V1 to V2 pattern change. This point I want to highlight, sir, because here we can see the prominent R wave in V1, and suddenly after that there is prominent S wave in V2. There is sudden transition of QRS complex in lead V1 to V2. It is specific of this condition with prominent inverted T waves in lead V1. This type of changes of we can find in TOF. Because there is thickening of R wave free wall, we can get tall R waves in V1. There is thinning of R wave trabeculum, so there is suddenly depression of R waves in lead V2, and after that there is thickening of R wave septum, so we can get the repeated tall R waves in V3 to V4. This is the next case, sir. This is 90 years of old girl with exertional fatigue, no spells or CHF, mild saturation, 12 flow murmur in pulmonary area, sir. Here we can see the prominent R waves in lead V1 to V6. All recorded leads are prominent R waves. Here we can see that prominent R waves with clockwise loop, and there is here we can see also that there is a tall P waves. In this condition, we have to suspect TOF with absent pulmonary also. This other ECG, suggestive of pulmonary atresia with VSD. It also presented as the VSD PS morphology, that is same as TOF. Here we can see. Other diseases like double outlet right ventricle, it varies with clinical types. RVH right ventricular hypertrophy is usually in this condition. Subaortic VSD with PS present with a TOF-like feature. Subaortic VSD with no PCO present with endocardial crucial defect like physiological left axis deviation. Subpulmonary VSD TJ-like features present with right axis deviation, right ventricular hypertrophy, LV volume overload, and first ventricular. This other ECG of 20 months of child presented with congestive heart failure, systolic murmur with mild cyanosis, X-ray history of cardiomegaly, and with increased pulmonary blood flows. Here we can see that counterclockwise loop, left axis deviation is there. There is no RV force we can see here, and total LV dominance with LV strain pattern. This ECG typical of tricuspid atresia, so it signifies there is no all work is done by left ventricle, so there is this type of ECG changes are there.
How do you differentiate congenital aortic stenosis and tricuspid atresia? See, the tricuspid atresia was a left ventricular tremors.
Yes.
In the congenital aortic stenosis also you get left ventricular. How do you differentiate? What is the differentiating point?
Specific, sir, plus either I want to highlight is no RV force. There is no recorded R waves. V1 में R wave चाहिए first, and second is left axis deviation. Main thing I want to highlight is RV force is not there, sir. That is the main. And both aortic stenosis and tricuspid atresia present with left ventricular hypertrophy and LV strain pattern. But in aortic stenosis has some R waves recorded V1 to V2 leads, RV leads.
So this loop is counterclockwise or clockwise?
Counterclockwise, sir. DPS waves in V2 leads.
There are no S almost in V4, V5, V6.
Yes, sir. No S. So then, because of the upset one waves loop can be not definitely.
So जे देखाई छे उसके ऊपर तो ये क्लॉकवाइज है ना?
हाँ सर.
काउंटर क्लॉकवाइज कैसे लिखा है?
Yes.
Isn't it? अगर काउंटर क्लॉकवाइज होता
clockwise.
The lead transition can be unreleased. Counterclockwise अगर होता है तो.
अगर काउंटर क्लॉकवाइज है मतलब आपका जो प्रोमिनेंट एस आ रहा है आपका V4, 5, 6 में, right? That is what you want to say as much, which is much more than V1, V2, V3.
Yes.
Right? और V1, V2, V3 में ज़्यादा आ रहा है और V4, 5, 6 में कम आ रहा है।
Clockwise.
क्लॉकवाइज। ये क्लॉकवाइज वाला है ना सिस्टम?
Yes,
तो
clockwise.
अगर ये क्लॉकवाइज वाला सिस्टम है तो इसमें आपका LVH दिखा रहा है।
हाँ.
RV फोर्स नहीं है जो आप बताना चाहते हैं।
Yes. So other disease, hypoplastic left heart syndrome, it can present with the right excavation, right atrial hypertrophy, with right ventricular hypertrophy, with STD abnormalities in left precordial leads. It doesn't have any specific pattern. It just presents with the chamber enlargement criteria. So these are other specific cases I want to highlight. There is a 10-month-old boy asymptomatic evaluated by left sternal broader murmur. No cyanosis, X-ray history of mild cardiomegaly, normal pulmonary blood flow patterns. Here specific I want to see morphology of QRS complexes in this patient. These are called as fragmented QRS complexes, typically observed in Epstein's anomalies. This is a case of Epstein's anomalies. What we can get is high voltage P waves, Himalayan P waves in due to right excavation. There is long PR interval in normally Epstein's anomaly, but can be short when it associated with WPW or other pre-excited syndromes. There is dented fragmented QRS complex, and number of fleets showing fragmented QRS is significant of the disease. That is, here we can see fragmented in lead 2, 3, AVF and V1, V2, V3, V4, V4, 4 leads. So it is a specific typical pattern of Epstein's anomalies. There is a typical RBM morphology. The initial Q waves in V4 or even up to V4, V1 and even up to V4 can be observed. Lead AVR look like V1. Like here we can see that there is a notch complex in lead AVR which somewhat look like V1. And atrial fibrillation and atrial flutter are common in Epstein's anomalies. This is the last case. There is a 21 days baby presented with congestive heart failure without any murmur. X-ray history of cardiomegaly. Here ECG we can see that there is an anterolateral wall MI pattern. There is deep Q waves in inverted D waves in anterolateral leads. Here we can see that. When we get a child with ischemic changes of ischemic heart disease, we should think of L-kappa, anomalous origin of left coronary artery from pulmonary artery. There are various diseases that mimics the infarct pattern in children, includes L-kappa, coronary artery anomalies, top with coronary artery abnormalities, hypertrophic cardiomyopathy, coronary disorder, embolic manifestations, and Kawasaki disease. So whenever we got child with infarct pattern ECG, we should evaluate for these conditions. So, to conclude this session, with ECG provides a wealth of information and fundamental clinicals in assessment of congenital heart disease. In adult previously undetected congenital heart disease such as AST, Epstein's anomaly, congenital heredity or cardiac malformation, the ECG provides important diagnostic clues. Serial ECGs may be valuable in screening of hemodynamic ramification of congenital malformation, particularly the obstructive lesions. Moreover, in certain pathologies such as TOF, individual measures and changing parameters provide clinically pertinent prognostic information for high risk